Hi, good afternoon again. This is my second talk, and the title of the talk is Emerging Biomarkers in Frailty. So, for objectives, I'd like to review and summarize the current evidence on the validity and practicality of the most commonly used biomarkers for frailty, and look at the upcoming potential biomarkers and strategies to identify the presence or absence of frailty. Frailty has a lot of definitions, but I think this is my favorite one. It is used to describe a subset of older adults who appear weaker and more vulnerable than their age matched counterparts, despite having similar comorbidities, demographic, sex, and age. Its diagnosis is clinical and usually based on a specific criteria, which are sometimes inconsistent. Therefore, there is a need for a more robust or dependable biomarkers to guide clinicians like us. The frailty criteria. There is no accepted reference standards that exists to identify frailty, and extensive international efforts are underway to identify the means of optimal measurement. It can be defined by using the physical phenotype model of Dr. Freud et al. Its rapid screen called FRAIL. It can also be defined by the concept of deficit accumulation model of Rockwood and Minitsky, which captures the multimorbidity of this syndrome. It can be identified through mixed physical and psychosocial models such as the Tilburg Frailty Indicator and Edmund-Ton Frailty Scales. There's a lot of scales that are being used for frailty, to diagnose frailty or to identify frailty, but that is not our objective for today. But I'd like to mention the frailty as a syndrome or phenotype as proposed by Linda Freud and others working on the cardiovascular health study. It is a claim that frailty is a result of dysregulation of stress response systems, responsible for the organism resilience, leading to loss of homeostatic capabilities and increased susceptibility to stress, or homeostenosis, and the emergence of a distinct syndrome phenotype that is predictive of a range of adverse clinical outcomes, negative clinical outcomes. This is a busy slide that shows the entire gamut of factors that may interplay to produce frailty. From your right side, it starts with sarcopenia. On the left upper corner is decreased total energy expenditure. You can see the end result as decreased resting metabolic rate and resulting to chronic undernutrition and more loss of muscle mass. This is a vicious cycle created by aging and senescent musculoskeletal changes. It starts with sarcopenia created by aging and possible contribution from chronic degenerative diseases and chronic malnutrition. In another slide by Halter and Auslander, you can see here from your left side as the causative factors like molecular disease processes like oxidative stress, mitochondrial deletion, shortened telomeres, DNA damage, cell senescence, and gene variations and inflammatory diseases causes impairment in the physiological response, which release the inflammatory cytokines, which contribute to sarcopenia and osteopenia, and combined with the neuroendocrine dysregulation by insulin-like growth factor 1, dehydroepiandrosterone sulfate, sex steroids, results in the 5 syndromes of slowness, weakness, weight loss, low activity, and fatigue. This is the frailty syndrome according to Dr. Freud and colleagues. Characteristics of frailty are classified into weight loss, number 1, number 2, weakness, number 3, exhaustion, poor endurance, and number 4, slowness and low activity. And the measurements are on the other side of the table. The presence of 1 or 2 classifies the patient into a pre-frail status. The presence of 3 or more of these characteristics of frailty puts the patient or diagnoses the patients as having frailty. In another concept developed by Dr. Ken Rockwood and colleagues, frailty is considered as an accumulation of illness, signs and symptoms, and laboratory abnormalities based on the observation that the more things individuals have wrong with them, the higher the likelihood that they will be frail. It's called Frailty Index. It's an alternative method of identifying frail older persons with 70 clinical deficits, and also identifies the severity of current diseases and ability to do the activities of daily living, combined with your physical examination and your neuro examination, and it is scored according to frequency and severity. Frailty Index is again a deficit accumulation index, usually referred as Frailty Index, and it is a stochastic accumulation of structural and functional deficit in almost any physiologic system or organ, and operationalizes it as simple unweighted count of the number of deficits. The proportion of all potential deficits considered for a given person, rather than a specific nature or combination that best expresses the likelihood and the severity of frailty. Okay, in summary, you can see this in the frailty scale, clinical frailty scale. We see the patients as classified as very fit, as well as those managing well, those vulnerable, mildly frail, moderately frail, severely frail, very severely frail, and those who are terminally ill. Another way of looking at frailty is to look at the layers of frailty, as again from Halter and Auslander, from the Hazards, Geriatric Medicine, and Gerontology. Frailty is described based on 3 layers of concepts. The one is the clinical presentation, and the middle one is area of biomarkers, which we will discuss, and the inner circle is the primary cause. First layer is clinical presentation. It's composed of multi-morbidity, impaired physical function, cognitive impairment, and mental health problems. Examples of these are slowness or walking speed, a poor lower extremity performance, reduced physical activity, reduced muscle strength, and poor memory, number of diseases or comorbidities, number of drugs or multi-pharmacology. Also included are reduced functional reserve, impaired resilience to several stresses, and delayed and incomplete recovery. The second layer is the area of biomarkers, which we will discuss more extensively. Includes muscle mass and strength, fat muscle increase beyond what is expected of aging, and bone fragility. Level of fitness is poor, accompanied by altered resting metabolic rate due to, in part, to change in body composition, and in severe cases to impaired oxidative capacity, with reduced energetic efficiency, resulting in fatigue and reduced mobility. Impaired homeostatic mechanism, low reserve, reduced ability to respond to perturbation, reduced ability to recover. The third layer is the biological basis, the hypothetical basis for making a connection between the biology, the basic science, and the experience in geriatric practice. So let's go directly to biomarkers. The problem with biomarkers, and I'll tell you this right away, is that most of the biomarkers considered for frailty are also biomarkers of aging. Hence, the capacity to differentiate between the two depends on the experience of the clinician. But more importantly, there is lack of acceptable standard differentiation between the two. The most popular one is the inflammatory markers, like your C-reactive protein, the interleukin-6, the TNF-alpha, tumor necrotizing factor alpha. Second most popular ones are the hormones, the DHEA, testosterone, IGF-1, and vitamin D. Clinical parameters such as hemoglobin, GFR, albumin were also considered. And the products of oxidative damages like AGEs or advanced glycosylation end products, your oxidized LDL, protein carbonyls, and the antioxidants sirtuins and alpha tocopherol. We'll take them one by one. For inflammatory markers, TNF-alpha and interleukin-6 are cytokines which are commonly involved in acute phase response. It is produced by various cells like myocytes, the macrophages, and adipocytes. It correlates with components of frailty, especially those decreased in muscle mass, grip strength, and bone mass, as well as depression. C-reactive protein is a byproduct of acute phase reactants, closely linked to osteoporosis and other components of frailty. Also, CRP correlates well with negative patient outcomes. The problem is these markers are unable to predict the transition from robust to pre-frail to frail. And the usefulness in early identification or risk stratification and prevention is limited, and clear cut-off points have yet to be identified. The utilization as a screening tool is very unlikely. Hormonal changes, like the link between the hormonal changes and frailty syndrome, is their obvious effects on the musculoskeletal profile of an aging person. This includes the DHEA, parathormone, vitamin D, IGF-1, or insulin growth factor 1, precursor of your growth hormone. A decrease in testosterone has been also associated with frailty in both men and women. Studies not consistent on estrogen replacement therapy. Also, some studies suggest a screening role to predict frailty in men. DHEA, on the other hand, is a precursor of both testosterone and estrogen and have been studied extensively. Lower level is associated with frailty, and supplementation can improve musculoskeletal symptoms. Differences in metabolism and biology for men and women makes it difficult to research and apply clinically. The hormonal changes in the parathormone in hyperparathyroidism is a known factor in musculoskeletal fragility. Studies on association with frailty yielded variable results, and sudden elevation of parathormone levels correlated with a 2-year all-cause mortality in very frail patients with poor prognosis, potentially promising screening tool, as authors concluded. The vitamin D have also been seen highly prevalent in sedentary population, and low levels of it highly correlate with increased rates of frailty. Correlates well also with transition to pre-frail to frail and pre-frail to robust. It is important in the musculoskeletal system, maintenance and mood regulation, and autoimmune disease, among others. It has a very variable normal range because of the differences in geographic location, also affected by racial differences and the varying of seasons. IGF-1, a key anabolic hormone, has been associated with the host manifestation of shared by frailty. Low levels have been correlated with higher incidence of frailty. Components of it, like sarcopenia, increases in TNF-alpha, have a reciprocal decrease in IGF-1. The hormonal biomarkers have inherent advantages over the other types of potential biomarkers of frailty because its widespread use and well-evidenced cutoff values. They give indication to the underlying mechanism and diagnosis as well. Treatment of the underlying frailty presentation is possible. may have some capacity for screening and prediction of transition from pre-frail to frail. Another category called metabolic dysregulation. As many people now becoming diabetic, the increasing number of prevalence of diabetes in Philippines, this is very, very important. And the onset of frailty, the question of whether the onset of frailty is a part of a sequelae of diabetes mellitus, just like the cardiovascular and renal problems or chronic kidney disease secondary to diabetic nephropathy. Hemoglobin A1C, they say, is a promising biomarker for frailty risk. It is not yet shown to predict transition from robust to pre-frail or pre-frail to frailty. It's not been shown to correlate with poorer frailty health outcomes or disabilities. However, lower hemoglobin A1C have been shown to be associated with a fall in the frail elderlies. So that sort of complicates the role of hemoglobin A1C as a screening tool for frailty. Aging blood or circulating hallmarks of frailty was also considered. Decrease in levels of hemoglobin, decreasing levels of albumin and GFR shows a correlation with frailty symptoms. However, their relationship with other comorbidities makes it difficult to apply as a standalone indicator of frailty, meaning the direct relationship is very hard to establish. Other markers such as the oxidative markers and antioxidant concentration have also been considered. Indicators of oxidations like advanced glycosylation end products or AGS, protein carbonyls, oxidized lipoproteins, and antioxidant deficiencies have been associated with frailty. The major challenge is in using it clinically is that they are also associated with normal aging process, just like the ones that I mentioned earlier. The new ones, like the circulating osteoprogenitor cells, offer some promise. These are the new biomarkers for frailty. There are mesenchymal cells or circulating macrocyclic cells that are found in almost all tissues when they undergo repair process and renewal. And it's been popular to harvest them from the umbilical cord, adipose tissue, even peripheral blood, liver, amniotic fluids. However, there are differences in the activities and gene expression profiles of these mesenchymal cells. The circulating osteoprogenital cells or COP cells are considered surrogates of marrow stem cell population. They behave like mesenchymal cells and have been studied extensively in vitro or ex vivo. Can be isolated from the mononuclear cells in the blood. It can pass through the endothelial barrier because it's in the fluid phase. It's a good source of stem cells with mesenchymal potential, especially for musculoskeletal disorder. These circulating osteoprogenital cells have been studied. It's called the COP study. It's a cross-sectional study in healthy conditions among healthy population, involving 144 healthy volunteers from Western Sydney, with the age ranging from 20 years old to 90 years old, involving 10 male and 10 female per decade. They have found that circulating osteoprogenital cells or COPs behave in a very stable manner, just like components of your CBC during normal conditions. They can predict that 42% average percentage in the peripheral blood mononuclear cell population exists during normal conditions. And the age and sex independent reference range of COP percentage is 0.01 to 3.8%, quite manageable, which suggests that the percentage COP may be compared to components of blood counts like neutrophils, which remain stable but are affected by disease. These circulating osteoprogenitor cells were found to be associated with calcific aortic stenosis and excessive endothelial and cartilage growth and calcification. In the Nepean Osteoporosis and Frailty Study, or NOF study, where they hypothesized that low percentage COP is associated with frailty. And methodology included random sampling of community dwelling and residential aged care volunteers, 65 years and above, mean age of 82, and was classified through using the frailty criteria of Fraid et al. And Rockwood et al. Models. It showed a sensitivity of 93%, a specificity of 89% of COP for the diagnosis of frailty. It's a very, very high sensitivity and specificity, differentiating those with frailty and those without frailty. Another biomarkers that's been studied is the lamin A and the COP cells. No? It's the author said that this is a robust biomarker for frailty. The lamina consists of a network of proteins called lamins, with three major lamins identified as lamin A, lamin B, and lamin C, with lamin AC involved in cell differentiation. In aging mesenchymal cells, the nuclear lamina is believed to play an important role, assisting in the differentiation into myocytes, or the muscle cells, and osteoblasts, or the bone cells. Lamin plays a very important role in mesenchymal cells and mesenchymal diseases. Lamin plays also a potential impact on aging process, in particular, the progression from healthy aging to frailty and disability. And they have shown that low lamin A COP was strongly associated with frailty. In frail individuals shows 60% lower lamin A COP compared to robust subject, and 62% lower compared to pre-frail subject. The association between low lamin A COP and frailty is stronger than using COP alone, or circulating osteoprogenitor cells. Despite this promising evidence, however, the supporting use of percent COP and lamin A COP as a biomarker for frailty, it needs longitudinal studies. Assessing their sensitivity, specificity, and predictive value still apparently required for long-term outcomes. Since the basis for the studies that I mentioned are cross-sectional, they need to do a longitudinal studies, and I think this will be coming out soon. So in the future, the biomarkers of frailty, frailty is moving into the realm of genetic and proteomic research with an astonishing speed not possible before due to technological advancement. Changes in the proteome of patients have been hypothesized as could be the unifying pathophysiologic process underpinning accelerated progression into frailty. The proteomic indicators that are being studied right now includes angiotensin, haptoglobins, fibrinogen, antithrombin, and transferrin. And genetic cause and aberration in protein expression is also being studied, as well as gene regulation. So this is where the battlefield is right now, genomics and proteomics. These are part of molecular biology. Genomics is a study of the genome or the genetic codes that includes your messenger DNA, messenger RNA, and conversion to proteins. Proteomics is a relatively new science in the area of molecular biology, but it's said that this is more important in understanding the cell physiology, because you are now actually looking at post-translational situation where you see the interaction between these different proteins inside the cell. There are more than thousands of proteins inside the cell, and what proteomics does is to understand the totality of all these enzymes and understand the cellular physiology. And from there, perhaps we can find something that is valuable in classifying our patients into pre-frail and frail, and vice versa. So, in summary, the life expectancy is increasing worldwide, and the incidence and clinical consequences of frailty will also rise with it. Therefore, Early diagnosis of frailty is pivotal to prevent disability and adverse outcomes. My only hope is that these appropriate frailty biomarkers becomes available in our lifetime. For your sake, for my sake, and for our patients' sake. So for that, I'd like to thank everyone for listening. Thank you.